Hello and welcome to Talking General Practice, the podcast from GP Online. I'm Emma Bauer, the editor of GP Online. Today on the podcast, I'm joined by our deputy editor, Nick Bostock, to talk about the latest news affecting general practice. Coming up, we're talking about the ongoing dispute between the BMA and the government about this year's GP contract and what the BMA will be asking GP practices to do from the 1st of June as it steps up collective action. We'll also be talking about a vote at the UK LMC's conference earlier this month, which saw LMC representatives back exploring the radical step of moving towards a hybrid NHS private model for general practice. We're discussing the government's new health bill and what that means for general practice, in particular the plans for a single patient record. And we'll be talking about an update NHS England published on the GP contract at the end of last week, as well as looking ahead to the government's new NHS workforce plan, which is expected to be published next month, and what that needs to do to ensure there are enough GPs to meet the demands of an ageing population. That's all to come on this episode of Talking General Practice. MIMS Learning Live South is returning to London on Friday the 12th of June, and this year we're pleased to announce that tickets are free to book. This is the event you won't want to miss. It's your chance to boost your clinical know-how, connect with peers from across the UK and gain fresh insights that can make a real difference in your patients' lives. This year's clinical programme covers issues including obesity management, paediatrics, women's health and cardiology. We'll also be running a GP Business Hub stream aimed at GP partners, practice managers and PCN managers, which will be chaired by me. Sessions in that stream will cover practice finance, neighbourhood working, using AI in practice and how to meet the challenges of rising patient demand. Spots will go faster, don't wait. Head to mimslearninglive.com/south and grab your tickets today. And if you come along, do pop over to say hello if you see me. So Nick, there's absolutely loads to talk about this week. There's been so much going on since we last spoke, not least the resignation of Wes Streeting as Health and Social Care Secretary. But first off, should we talk about collective action and the UK LMC's conference, because they're quite interlinked. We're at the end of May now and the BMA have announced what it wants GPs in England to do to step up collective action from the 1st of June. This is all part of a protest against the imposed contract for this financial year, which GPs overwhelmingly rejected. So what are practices being asked to do next?
The current wave of collective action began at the start of May, and the BMA GP committee has said that each month it will step up action another notch to keep pressure building on the government over disputed changes to the contract for 26-27, as you said. The first phase at the start of May involved the BMA asking practices to limit data sharing. Practices were asked to use a template letter to tell their ICB that they would stop agreeing to voluntary secondary uses data sharing agreements. And the GP committee also asked practices to audit existing data sharing agreements and report any new requests around that to the BMA. But so far, nothing seems to have shifted. The first stage hasn't resulted in a shift in position from the government or NHS England. So from the 1st of June, GP practices will move into the second phase of action. And this time, the measure practices will be asked to take is around medicines optimisation and prescribing. An update from the BMA describing the measures that they're planning said they would be asking practices to remove or ignore any non-contractual medicines optimisation software and amend your choices of acute prescriptions which may fall outside the remit of the ICB formulary.
Why do you think the BMA is asking practices to do this? What's the point of this?
The point of these actions is broadly to stymie government plans and priorities, to make life more difficult for NHS leaders and ministers, in the hope that eventually they'll back down over concerns the BMA has about this year's GP contract and the implications it has for workload and ultimately patient safety. All the actions stop short of anything that would breach practice contracts at this stage. So practices aren't refusing to share data where it's a contractual obligation. And similarly, they won't be changing anything around medicines optimisation or prescribing that would breach their contracts. But the point of the first action around data sharing is essentially leveraging the power general practice has as the data controller for all the information held in patient records. Data sharing agreements are the mechanism that allow the NHS to use data collected via general practice at scale, potentially for research or to inform health service management. at-scale use of data is something the government's very much invested in. It's also a key plank of neighbourhood plans, a sort of foundation stone for those plans. So limiting sharing of that data is about GPs throwing a spanner in the works to make it harder for the government to achieve some of those aims. With a new measure that could kick in from the 1st of June, the pressure practices are putting on the system is operational, as with the initial phase, but this time it's also financial. This measure could mean practices prescribing branded or liquid medications that fall outside ICB formularies. And as the BMA has said, that could be a perfectly good choice, maybe even the best choice for the patient who's sitting in front of them in any consultation. But more branded medications could also drive up costs for ICBs. I'd look back at the measures GP practices were asked to take in 2024 when there was a previous round of collective action. And at that stage, there was a sort of menu of 10 options. And one of the options suggested then was to switch off medicines optimization software embedded by the local ICB for the purposes of system financial savings and or rationing rather than the clinical benefit of your patients. So that, I think, touches on what this measure is about. This is about GPs stepping back from that cooperation with ICBs over cost saving around prescriptions or around prescribing, and maybe at the same time actually making life easier for patients and potentially for themselves as well.
So since the last time we spoke, we've had the UK LMC's conference in Belfast. So this is the conference of LMC representatives from across the UK, all 4 UK countries. There were a couple of really interesting votes that happened at that LMC's conference, and as we were coming in to record this week's podcast, there's been some further developments on one of those stories. So I think the thing most people will have seen is that LMC's voted on moving towards a hybrid NHS private model for general practice, including balloting the profession in each country on introducing a means-tested subscription-based service similar to NHS dentists. So there were 4 parts of this motion, and underpinning all of them was this overriding theme that NHS general practice as it currently stands is no longer financially viable and something has to change. So the conference backed calls for a new contract that allows GPs to provide private services to their NHS patients where they're not provided by the NHS. So this is things like maybe private health screening or even weight loss jabs. You know, practices have patients that are already going elsewhere to pay for these things. So why shouldn't the practice themselves be allowed to provide them? That was what the speakers backing that motion were arguing, and that was supported by the conference. That was backed, that part of the motion. Then the other parts of the motion were all a version of a theme of effectively private general practice. The conference backed a move towards that hybrid NHS private GP service. It called for a strategy for exiting GMS contracts and future working outside the NHS, and it directed all 4 UK GP committees to ballot the profession on a Plan B option for general practice that included considering a means-tested subscription-based service that works in a similar way to NHS dentistry. And all 3 bits of that, the motion, those other 3 bits, they all passed as well. And I think, you know, it was a pretty significant moment. Nick, you and I have been to more LMC's conferences than I think either of us can count now. And over the years, these motions about more private work or moving outside the NHS, they come up every now and again, don't they? And they're always rejected. But this year it wasn't. And it was backed really convincingly. It wasn't a narrow vote by any stretch of the imagination. And I think, you know, that goes to show the level of frustration and concern about the future direction of travel and the lack of funding for general practice. There was a feeling that maybe this wasn't really necessary for Scotland, you know, given the deal that the Scottish GPC has negotiated with the government there for additional funding to employ GPs, and also a sense perhaps that maybe things are starting to move along the right track in Wales. But really in Northern Ireland and England, the consensus was that, you know, things are really heading in the wrong direction. There was a real feeling from people speaking that the BMA, the GP committees in all 4 countries, they needed this idea of voting on a Plan B option like dentistry in their back pocket, as it were, to strengthen their hand in negotiations. And a lot of really impassioned speeches about the level of work GPs face and the financial pressure practices are under. And just as we were coming in to record this podcast, the BMA GP committee in England confirmed that it was going to ballot the profession on this Plan B option and promised extensive consultation with the wider profession on their support for an alternative contracting arrangement for general practice in England. This is massive, really. The BMA told us that the ballot could take place any time up till June 2027.
Yeah, I mean, I think you're right that it's the fact that GPs are prepared to work in the NHS, prepared to consider an option like this, shows just the depth of concern about the long-term funding problems that general practice faces.
BMA England GP Committee Chair Dr Katie Bramwell said exploring an alternative model was a consequence of long-term political and systemic failure to protect NHS general practice and had left the profession deeply frustrated with no other choice but to explore alternatives. She said the need for the ballot could be prevented, but the government needed to urgently engage with the very real concerns GPs have about their core contract as well as their well-being and livelihoods, or we risk losing NHS general practice entirely, she said. But it's a slightly tricky situation, this, isn't it? I can see exactly why we've ended up here, and it'll be really interesting to see what happens with that ballot and how it develops. But if you're a Labour government faced with GPs prepared to leave the NHS en masse or pushing for a hybrid model, that is potentially a real problem for you as a Labour government. If you're Nigel Farage heading up a reform-led government or reform-led coalition government, maybe not so much. Maybe that's something you would welcome. So, obviously, as I say, it's a developing story as we record, and we'll need to keep a close eye on what's going on with that. So, Nick, Dr Katie Bramwell also opened that UK LMC's conference that we were talking about with a speech where she talked about collective action and the dispute. What did she have to say then?
The overarching message to GPs from Dr Bramwell's speech was really around the need to stick together, the argument that a united profession is a strong one and that rallying around collective action can be a powerful way to push back against the imposed contract in England, as well as more broadly the underlying long-term underfunding and workload pressures that GPs are facing. Dr Bramwell made the link between the measures around data sharing in the first stage of collective action and some of the concerns GP leaders have about this new legislation. So I think one of the oldest arguments GPs have always made when it comes to why they're concerned about data sharing or sharing the information collected in their patient records is that patients only share that information on the basis that they trust their GP, that they have faith that that information that they share in the consultation room is confidential. Back in the day, that information was, went into a Lloyd George envelope and was kept in the back of the surgery. Then it was in a server in the back of the surgery. I mean, sometimes maybe they were in the front of the surgery, who knows? But anyway, it was in a server that was in the surgery. It was not connected to the internet. It was an internal system. And then things shifted to cloud-based systems and so on. And suddenly all that patient data was outside practices physically. And that sort of shift really paved the way for data to be interrogated at scale in a way it hadn't previously been, and to become the really powerful population-level tool that governments and the health service and researchers see it as. But with each shift in how that data is stored and used, GPs have raised concerns about the potential impact on their relationship with patients. And Dr Bramwell made that point in her speech. She said an insistence on transparency, governance, proportionality and trust in how patient data was used was really key. And that once trust is lost, it would be extraordinarily difficult to restore and regain. So safeguarding that trusting relationship with patients around data is a major part of the basis for choosing limits on data sharing as the first step in collective action. And Dr Bramwell said, protecting that information is not about Luddism. It's not about rejecting technological progress or sort of restricting research. It's about consent and transparency. And she said challenges to that and to GPs' control over that information are something that'll be an issue UK-wide ultimately. So during that LMC conference, the news broke that Wes Streeting was resigning as Health and Social Care Secretary.
Yeah, it's interesting, isn't it? I mean, will it actually change anything? I mean, we're going to come on to talk about the health bill in a minute, and I guess the same question applies to that as well. Will having a new Health Secretary affect any of the things that are in the health bill, and what that ends up looking like after it's been through both houses. I wrote about Wes Streeting's time in office for the website, sort of look at his legacy, as it were. And obviously, there's a lot of things there. There's the 10-year plan, the abolition of NHS England, massive cuts to ICBs. They're all really significant things that kind of happened under his watch, or are in the process of happening. And the jury's out really on whether any of those things will actually deliver the benefits, he said they would, or he thought they would. But he also leaves the role with almost, every branch of the medical profession in England in dispute with the government. And I would say that his time in post really has been characterised by a very bullish and combative attitude to the medical profession, and the BMA in particular. One of the things, I guess, that will concern GPs about his departure maybe is what happens in terms of that plan for a big new contract Wes Streeting promised for the end of this Parliament, and also what happens with that Carhill review, the review of the GP funding formula, which he really championed, and he did get started. It's not really clear what this change in personnel will mean from both of them. But I think, rather tellingly at the LMC's conference, Dr. Katie Bramwell described the past 12 months of discussions between the BMA and government as, and I quote, an absolute waste of time. She said they were basically still talking about the same things they were a year ago, which is basically how can we make sure that online consultations are operating safely. So there's been little to no progress on that big new contract, because BMA is obviously focused on trying to mitigate the problems caused by the current contract. So, we've got new Health and Social Care Secretary now, James Murray. He's moved over from his previous post as Chief Secretary at the Treasury. And obviously, every new Secretary of State will have their own priorities, their own things they want to champion, their own way of doing things. I guess, this is a potential chance to reset that relationship with the BMA, GPs, residents, and potentially consultants and SAS doctors too, who are currently being balloted on strike action. But I don't necessarily see there being a huge change in, direction. There's still very little money around. That's going to limit what he can do. And as we've come in to record the podcast today, we've just seen that resident doctors have announced another 5-day strike for June. And that announcement came after a meeting with the new Health and Social Care Secretary. And then obviously there's the question of how long he'll be in post. If Andy Burnham wins the Makerfield by-election, if there is a leadership challenge, if Keir Starmer loses, if there's a new Prime Minister, presumably there'll be a new cabinet, new Health Secretary as well. My
prediction around that would be that James Murray probably won't be in post all that long. Obviously, there's a big if around whether Andy Burnham can win the by-election, whether he can oust Keir Starmer as leader of the Labour Party. But if those steps happen, I would assume that James Murray would be replaced by whom we don't know. And then actually, in the big scheme of things, I wouldn't expect a massive policy shift. You'd expect Burnham to try and reset some of that relationship stuff with the BMA. You mentioned the fact that, all these branches of the medical profession are in dispute at the moment. Beyond that, you wouldn't expect a gigantic policy shift. But what it does mean is a real sort of hiatus, a delay, and that all means, the chances of making any progress on that big new contract, or making progress on just next year's contract, is all on pause for the moment, potentially. There's lots of ifs about what could happen next, but it's unlikely we're going to see any concrete plans coming until, that drama in Westminster's all been played out. So, Nick, we talk a lot on the podcast about the GP workforce, don't we? And there were a couple of stories that you wrote during the past week or so that relate to this. We're going to come on to talk about the NHS workforce plan in a minute and what that might need to address in terms of the GP workforce. But first, let's perhaps look at this update to the GP contract that NHS England published at the end of last week. That included some clarification on the practice level reimbursement scheme to recruit GPs, didn't it? What exactly did it have to say? We've talked on the podcast previously about GPs and accountants saying that the rules around the scheme, the GP reimbursement scheme, are too restrictive, and the update from NHS England tries to offer some reassurance around how some of those restrictions will work in practice. One of the key points around this GP reimbursement scheme is that it's funded with £292 million that was transferred from last year's capacity and access funding for PCNs. So last year, PCNs could use the money in quite a broad range of ways, and often they distributed some or all of it to practices to help them recruit. And practices had quite a lot of freedom around this. They could bring in locum GPs or salary GPs or other staff as they saw fit. Under the GP reimbursement scheme, the money can only be GPs and it can only be salaried GPs, not locums. But NHS England's update offered a bit of extra information on this, and it said that where a practice has an existing locum GP working for them, they'll be able to use the GP reimbursement scheme funding to pay that same GP for extra sessions, but with the caveat that those extra sessions must be on an employed contract as essentially a new salaried GP.
Yeah, there are potentially some problems with that, though, for practices, aren't there?
Yeah, so I've spoken to accountants about what they make of this, and essentially they don't think NHS England has thought this through properly. The point they made was that they don't think a practice can employ the same GP to do some sessions on a salaried basis and some on a self-employed basis. That just doesn't work from a tax point of view, because HMRC would be likely to say this person should be paid through PAYE for the whole lot. They should be considered salary for all of the work that they do. So what are the implications of that? This could mean that practices are under pressure to try to convert their regular locums into salaried GPs, essentially. And that comes with a whole load of additional hurdles. There's a cost in terms of time and effort for practices in switching people over to different contracts, and then managing all the pension contributions and the national insurance and so on that come with shifting a regular locum to a salaried role. But then there's also the issue that people currently working as locums might be doing so because that's their preferred option. They might not want to switch, in which case, what does the practice do? Do they insist and risk losing a valued regular locum? Do they find a different GP prepared to work in a salaried role for all of the time that they employ that person for? Or do they try and find someone else to do a very small amount of work on a salaried basis and keep the existing locum? And that might be complicated because the funding from the reimbursement scheme only amounts to a couple of sessions per average practice. So the attempted clarification may have raised more questions in the end than it answered.
Yeah, well, there's a surprise, isn't it? Something new rolled out in general practice that isn't entirely straightforward. I mean, honestly, it's just all so complicated now, isn't it? The other thing we did about this on the website is that you also looked at the impact of that restriction on the reimbursement scheme, that practices with more than 3,500 patients per GP won't be able to access the money. I mean, what did you find with that?
This point was also addressed in the NHS England update. The rules around eligibility for the GP reimbursement scheme say that practices with more than 3,500 patients per GP must seek approval from NHS England to be eligible to participate. So it's not a complete barrier. They're not being told they definitely can't. There's that additional step. The average number of patients per GP across England as a whole is about 2,100. So the point here is that practices with particularly high numbers of patients per GP need to explain themselves to NHS England before they're allowed to claim extra funding under the GP reimbursement scheme. Sounds counterintuitive in that these are precisely the sort of underdoctored practices that might benefit most from extra support to recruit GPs. So why would you make it harder for them to access reimbursement scheme money? And the answer is that the NHS and the government don't quite trust GP partners. Their fear is that a practice with a really high number of patients per GP is just not investing enough of its existing funding in recruitment. So they want to check what's going on before they allow them more funding through something like the GP reimbursement scheme. NHS England's update said the 3,500 patients per GP rule isn't meant to be a barrier. It's meant to be, quote, a supportive touch point with the ICB to help understand the factors behind a practice's underdoctoredness. It does mean, obviously, that there's an extra step involved in being able to access the money. And from looking at the statistics around patients per GP nationally, the proportion of practices caught up by this rule is really significant. 1 in 7 practices, roughly, in England have more than 3,500 patients per GP. In some cases, practices may well be able to justify themselves reasonably easily. Perhaps they've tried to recruit and they can't, so they've invested more in other staff. That's something you often see where practices have low numbers of GPs for their patient population, they often have more nurses and other staff. But, I guess a practice in that situation might have to demonstrate that it has tried to recruit GPs. Or a practice might be able to show that they haven't been able to recruit permanent GPs, and therefore they use locums more often. And those staff maybe don't show up in the practice level workforce data quite so clearly. Some LMCs I spoke to said they are worried that depending on how the rules are applied, it could mean that some practices that really need the support, some of these really under-doctored practices need help to recruit, could be denied that help.
Yeah, I mean, there were some other things in that NHS England update on the contract as well, weren't there? Are any of those worth highlighting or mentioning?
There are some other basic points in there around how to claim and some of the processes and timescales involved. And so there's a piece on our website that describes some of that. Also, some clarification on wider contract changes, such as clarification that the demand for same-day access for urgent patients in this year's contract doesn't necessarily mean that they have to be offered a face-to-face appointment on the day.
The other thing you wrote about when it comes to the GP workforce, that's what we've been talking about, was the forthcoming NHS workforce plan. We've been waiting for this for quite a while now, haven't we? The government said as part of the 10-year plan that it was going to overhaul the current workforce plan, which was developed under the previous Conservative government to better reflect this shift towards community, the advent of AI. The story you wrote was about how important it is for the plan to prioritise the recruitment of GPs, wasn't it? What was that all about?
The main complaint GP leaders made about the existing workforce plan, which came out in something like 2023, was that it just didn't go far enough around recruitment and particularly retention of GPs. The National Audit Office said in 2024 that the plan was built on substitution of GPs with other types of health professional within general practice, and it also meant that other types of doctor within the health service would grow far faster than GP numbers. One of the key statistics on that was that the current workforce plan suggested GP numbers would rise by 4% by 2036, compared with 49% for hospital consultants. So hospital doctors would grow 12 times faster than GPs under the plan as it is. The additional roles reimbursement scheme was a really key factor in all of that. It can now be used to recruit GPs as well as other staff, but for several years up until 2024, that was not the case, and it was explicitly for recruiting other staff who were not GPs, and it was this more than £1 billion a year scheme to bring in those other staff. And it led to GPs being outnumbered by about 3-1 by other staff in general practice, according to one report. The current government has promised a refresh of the plan, like you say. It's said that will mean more GPs. But as you mentioned, the update's been delayed. We're expecting it fairly soon now. And the story we ran in the past week was about a warning from a think tank, the Nuffield Trust, that a new NHS workforce plan needs to make GPs the fastest growing clinical group within the health service, particularly to deliver the shift of care out of hospital that the government wants to see, and key policy aims such as creating neighbourhoods, as well as to meet the demands of a rapidly changing and ageing population. So we'll find out soon whether the government is listening.
On that, it's quite interesting. A week or so ago, the Financial Times actually ran a story about the NHS workforce plan. Its journalists had seen a leaked copy of the plan, which basically said that the plan would scale back the current plans, the Conservative government plan's ambition to hire thousands more nurses and doctors by making greater use of AI. I mean, that's not necessarily a surprise, really, because the 10-year plan had already said that the workforce would not need to grow as fast as previously expected because of all the efficiency gains that apparently the NHS is going to make with AI. So it's not talking about cutting back staff, but it's talking about not growing the workforce as quickly or as much as had been expected. But the FT story did say that the draft version of the plan that it had seen said there wouldn't be a substantial increase in doctor numbers, but rather a focus on shifting doctors out of hospitals and into the community. And the priority would be given to training and recruiting staff who work in the community, including GPs. In fact, according to that draft the FT saw, the plan at that point said that up to 49,000 more GPs might be needed by 2035. And that rise in GP numbers would come at the expense of those working in hospitals. And if that's true, that is an absolutely huge increase. And it raises all sorts of questions about funding for general practice, estates, infrastructure, training, massive questions that the government would have to answer if that GP workforce increase is its aim. But all of those issues were ignored in the previous workforce plan, and I would find it a surprise if this new plan actually addressed those really fundamental issues. Yeah, as you said, we're expecting it quite soon, so we'll need to wait and see exactly what it says.
That number being so vast, 49,000, you'd think that factors in a lot of attrition, numbers of GPs leaving the workforce, and also some issues around the full-time commitment of GPs and the fact that GPs are increasingly working less than full-time, even if, less than full-time often amounts to what most people would consider a full-time job. I assume that figure probably needs some interpretation, because obviously 49,000 more GPs is an absolutely colossal number. We've mentioned Wes Streeting resigning, but just before he resigned, the government set out its legislative agenda for the next Parliament in the King's Speech. One of the parts of that was a new health bill, which sets out the legislation for many of the things that Streeting championed in his time as Secretary of State for Health and Social Care. So, Emma, you've been looking at that. What does the bill cover?
Yeah, well, it covers quite a number of things. I'm sure a lot of people will have heard about this, but just to quickly run through them, they can broadly sort of be broken down into 4 areas, really. So this is the legislation that will scrap NHS England and move those functions into the Department of Health and Social Care. There are also some changes to ICBs that I'll mention a little bit later. The second thing is the bill will also scrap Health Watch and move the National Health Watch functions into a new patient directorate in the Department of Health and Social Care. Local Health Watch functions will be transferred into ICBs, and the other thing around that is the Health Services Safety Investigations Body. That's going to merge into the CQC. This is the legislation that will enable that to happen. There are quite significant new powers given to the Secretary of State under this bill, and I think some of that's going to be quite contentious. So the Health and Social Care Secretary will be able to issue new directions to ICBs, cap the amount NHS trusts can spend, have more freedom to remove NHS Foundation trust status, and potentially fire individual directors in trusts, and also have a say over who should be appointed to ICB boards. The big one for general practice, and the thing that most GPs will have heard about, is it sets out the legislation for creating the single patient record.
That sounds like a big deal for general practice. What does it say about that?
Yeah, so this is potentially a massive change for GP practices. The legislation as it stands would require all NHS and social care providers, obviously including GP practices, to share data for the single patient record, and then also give the Secretary of State the power to fine those who fail to do so. The government put out a number of documents around the same time the bill was published, providing quite a lot of background information. Those documents say the plan is for all patients to have access to this single patient record, their patient record, via the NHS app from 2028, and eventually they'll be able to feed into that record themselves, write their own notes into it, I imagine. The government says that all of this is going to give people a greater control over their health and care. And you touched on it earlier, Nick, and the government also sees the single patient record as kind of essential for future health planning, for delivering a neighbourhood NHS, also for leveraging the power of new tech and AI in terms of, increasing productivity, secondary prevention of disease, all sorts of things, really. I think it really underpins a lot of what the government wants to do. So the record would include a patient's basically complete medical history, including care plans, prescriptions, results, treatments, basically pretty much everything. And this is quite crucial because NHS England is being scrapped. The overall responsibility for that patient record, single patient record, and for deciding on data sharing of information in that record, widespread data sharing at that top level, that responsibility will move to the Secretary of State as part of that abolition of NHS England, although obviously all of that data would be subject to other separate legislation around data and data protection, GDPR. I suppose a common complaint from patients is that they constantly have to repeat their story over and over again each time they attend a new hospital appointment or see a different healthcare professional. And because of this, the government says that support for a single patient record is pretty widespread among the public. And I think it is. There's no doubt, that some form of data sharing would help improve care, help with things like population health management, research, all sorts of things. But I think, there are some pretty significant caveats to that. I was at a King's Fund webinar about the bill, and one of their experts was talking about this, and he was saying that while patients are supportive about the single patient record, that's very much based on conditions such as transparency over who's accessing their information, accountability for what happens if things go wrong, and having a choice about how their data is shared. And I think there will be some flashpoints as the bill moves through the Commons and the Lords about some of these things and whether the bill adequately addresses those concerns. One example is that some of the current statutory guidance on data that NHS England is subject to, which includes principles of security and transparency and requiring NHS England to minimise conflict of interest, some of those sorts of things, those requirements don't pass over to the Secretary of State. They're just basically gone. So I think there's definitely questions from MPs and peers there will be about that. And I think the public might also become more concerned about some of these issues. It's one thing, having an arm's length body like NHS England or the NHS being responsible for a single patient record, perhaps quite another, for the government itself to be responsible for it. And some people, they might feel a bit less confident or a bit more uncomfortable with sharing their data when they realise that that's what the bill is effectively doing. It's giving the government control of this. And I think it's important to mention, the other thing it's important to mention about this is all just primary legislation setting out the overarching legal framework for this to happen. How it will actually work in practice would need to be set out in further regulations, including how fines would work, how much you could be fined if you didn't share data, how providers would be compelled to share data, all of that stuff, it still needs to be worked out in detail. So there's a lot of missing information.
It's interesting, isn't it, on a macro level? Back in 2012 with Andrew Lansley's reforms, the big concern was all about he's handing over power to other people, responsibility to other people. He doesn't want to take responsibility for anything. The health secretary won't be able to be blamed for anything at all.
Yeah.
And now it's all about, the health secretary's, this is a massive power grab, taking control of everything. So it's the diametric opposite. But these poor politicians, they can't win. Yeah, so anyway, GP practices and therefore partners are the data controllers for the records in their practices. What does that mean, and how would this legislation change that?
Yeah, well, that's one of those things that's very unclear, really, as part of this primary legislation. GPs, as you say, currently liable for keeping the data in the GP patient record safe and secure and responsible for any breaches of that data, and they can face really, really hefty fines if there are data breaches. So what happens to that liability when it comes to the information that they pass on to the shared patient record? It's really not clear, and that's going to have to be addressed. There's going to have to be some sort of decision about who's liable for that data and how's that going to work. Interestingly, the Doctors Association UK said they were really significant concerns within general practice about all of these plans. Their GP co-lead, Dr. Sarah Jacks, told us that the plans go far beyond improving direct clinical care and raise serious unanswered questions about confidentiality, governance, liability, transparency and public trust, and about, what happens and who's responsible if data from the GP record is changed or altered by other providers. These are potential scenarios we could see. And I think, there are also some questions over what this means for the doctor-patient relationship. It's kind of what you were talking about earlier with Katie Bramwell's speech. Practices and hospitals as data controllers, does that change how comfortable patients are with sharing their information, knowing that data is being looked after by that organisation? If people know it's going outside that organisation, will it affect what they're prepared to discuss, what they're prepared to share? These are all concerns that doctors are raising.
Do we know how it's all going to be delivered?
No, not really. Those supporting documents the government released alongside the bill, they say the government hasn't decided how it's going to do this, but it will be designed to integrate, with the existing architecture, not make any additional demands on providers. The plan, as far as there is one, is to build on and connect existing systems, and it will be delivered through contracts apparently with multiple suppliers, with no single supplier dominating. No decision about who those suppliers will be. It's not totally clear if it's going to be a completely new patient record that everyone will write into, or just more of a data sharing exercise where everyone can see connected records from different parts of the system. On top of that, obviously, data privacy campaign is really concerned about the involvement of the controversial US company Palantir, whether they're going to be delivering this. Palantir currently has the contract to deliver the NHS Federated Data Platform, which is the platform that enables data sharing across the NHS. GP practice is not currently connected to that, but trusts and ICBs are. That platform will obviously be involved in the single patient record, but exactly how that will work and what information Palantir will have access to, that's not clear. And obviously, I suppose the other concern is that the NHS and the government has a pretty poor track record of delivering on these massive IT projects. I mean, Nick, I seem to remember many years ago you writing about the National Programme for IT. I mean, that didn't really get very far, did it? So I think there's a lot of, concerns that really need to be worked through.
It's maybe not just massive IT projects, is it? Maybe just massive projects. You could probably do HS2 or whatever. Anyway,
Exactly.
And the BMA generally isn't very happy about these proposals.
No, it's not. I mean, you touched on a lot of those concerns earlier, didn't you? And I think we said on the last news podcast when we were talking about the first steps in collective action around data sharing requests that the BMA GP committee said that the government hadn't spoken to it at all about these plans for a single patient record and what it would mean for the data that GPs are currently responsible for. I mean, that seems baffling, really, seeing as, it's going to have such a huge impact on GPs' role as data controllers. As we've talked about, it seems baffling the government hasn't spoken to them. In an update to GP members this week, BMA GP Committee Deputy Chair Dr. David Wrigley described the plans, as the term you use, the plans as a power grab by the government that lack protections for patients. He shared a link to the data privacy campaigners' Med Confidential briefing on the plan, actually a link that Dr. Katie Bramwell's also shared on social media. And that briefing, highlights a lot of concerns that people will have about this. And I think because of those concerns, it's not going to have an easy ride through Parliament. And, that's where a new Secretary of State could have a big impact. Wes Streeting really believed that all this data sharing was essential for everything he was trying to do in the NHS. I mean, when this new Secretary of State comes up against opposition to some of these plans, whoever it is, will he or she be so driven to get it through Parliament? There's big questions about that.
Is there anything else in the bill that GPs should be aware of that's likely to affect them directly?
I think the only other thing worth highlighting is the changes to ICBs. I mean, we've done an article about lots of the things in the bill. You can have a look at that on the website. But the other thing that is worth mentioning here is about the changes to ICBs. So the bill is going to remove the requirement for ICBs to have a board member who represents general practice, as well as remove the requirement for ICBs to have a board member that represents local trusts and one that represents local authorities. Instead, they will be required to have board members who have been nominated by each elected mayor in the area. So that's quite a big change. I mean, the RCGP have already expressed real concern about that plan. The college says that for neighbourhood health to be a success, it's essential that GPs are really central to local leadership and decision making. So it says this is a real backward step. This was actually one of the issues it highlighted in a recent letter to the new health secretary. So I think that will probably be an issue that the college will be lobbying on behind the scenes in any meetings it has with the Department of Health. It's obviously something it feels quite strongly about. Well, that's it for this week. Thanks to Nick and thanks for listening. I'll be back next week when I'm speaking to academic GP Dr. Nada Khan about the recent research she's undertaken about why experienced GPs are leaving general practice and, more importantly, what changes the NHS and the government could make to keep them. In the meantime, don't forget you can keep up to date with all the latest news affecting general practice and access lots of other resources on our website at GPonline.com.